Never mind. How are you, Maud?
I'm good. How are you, Stephen?
Excellent. You've been in the sun all day.
Yeah, I've been to the park today.
Excellent. Good. You enjoy yourself?
Yeah, it was really nice. Thank you.
Brilliant. Good. So tonight, if you're just joining us live on Perfect Balance Clinical Power Hour, we are going to be talking about shoulder and shoulder injuries. So, Maud, do you see a lot of shoulder injuries in clinic?
Yeah, shoulders injury, that's quite common. I think they always come a bit different in each people, but it's a very common injury that people get, and it's a very common thing that I try to help people with.
Great. Are there common things that, before we go into the common symptoms that people get, I would think in clinic it's really good to understand a little bit about what makes a shoulder, because I think it's a very different joint, isn't it, to the rest of the other joints in the body. But what do you think makes the joint different to other joints?
I think the main thing with the shoulder, so it's a ball and socket joint, so it means that the joint is kind of a round surface like that, with the ball kind of coming inwards, which means that we can do a lot of movement with our shoulder. We can go backwards, up, inwards, like we can really go through the whole movement range of motion of the shoulder. And that's a particularity with the shoulder. We have a bit of the same with the hip, which is the same type of joint, but I'd say we have way more movement going through the shoulder. And then the stability comes from all of the muscle that then wraps around it and maintain it together.
Yeah, it's interesting, isn't it? Because from an evolutionary point of view, if we did walk on all four limbs, it's quite symmetrical, isn't it? So you've got the hip joint, which is a ball and socket joint, and then you've got the shoulder joint, which is also a ball and socket joint. But from an evolutionary perspective, as we've gone up onto 2 feet, what the shoulder joint has changed in terms of its anatomy, it's sacrificed mobility, so it's very mobile in terms of the joint, but it's very unstable, isn't it? So it's not a very stable joint. So most of the issues that people get with their shoulder later are actually related to that process of change. So most of the issues that people get with their hip are actually related to compression and too much forces. So it's quite interesting, isn't it, that there's a reason why these things happen, or why we think they happen, and there's logic behind the madness.
Yeah.
So the shoulder area, there's 4 joints, aren't there, that make up the shoulder joint, and one of them's often forgotten. But what are the main 3 joints? And if you know the 4th one, that'd be great as well.
Yeah, so the GH, so the glenohumeral joint. Yeah. Then you have the scapulothoracic joint, which is the big bone at the back, and then the ribs, which is not actually an articulation, but we still call it a joint. And then you have the acromioclavicular joint, and then the sternoclavicular joint, which is just at the front here with the sternum.
You got it. That's the one that most people forget, that one, don't they? But it's it's really interesting, isn't it? Because that joint there is responsible for the whole of the shoulder complex attaching onto the body. So it's the only actual bony attachment of the whole of this upper limb onto my body, which makes it stable. So I just find that fascinating, don't you?
Yeah, definitely.
It's literally the size of your thumb. It's a funny S-shaped joint that just sits here, but
it's just like a clavicle that comes in, and then your whole shoulder kind of relates to that. So yeah, it's really interesting.
Yeah. So the clavicle, I have a particular love of the clavicle. I don't know what it is about the clavicle, but I used to obsess about it. I think it was my name's Stephen, and it's like the letter S, isn't it? And I always used to remember that. So for some reason, I used to obsess about clavicles. But
that's interesting.
It's a really interesting bone, isn't it? Because if you fall, because of the way it's shaped, it helps to absorb some of the shock, but it also creates a bit of a weakness about halfway along. So when you fall and you fracture your clavicle, it normally occurs like smack bang in the middle, or at least the outer 2/3. And that's purely because of the shape of the bone there. So I think that's really interesting. There's also a ton of muscles that attach onto the clavicle as well, which often when we're doing treatment, and I've kind of picked up or inherited patients from other people, it's an area that often, for me, doesn't really get treated that often. So I often spend a lot of time doing kind of soft tissue work, so massage work around the collarbone, so the platysma, the trapezius muscle, The pec muscle as well, that's really important because that attaches onto the collarbone up here. But yeah, I think it's just such a fascinating bone.
And there's also lots of lymph nodes as well. That's all around there, just at the back and everything for drainage and everything. So it's actually a really important area to keep mobile and to keep moving for fluid drainage.
Yeah, and that for me is like, I think that's what floats my boat really, is because that small fact there is really responsible for pretty much every disease or every problem that people get is in the upper limb. If that clavicle, the collarbone, isn't moving or can't mobilize and move around very well, you get an injury. It doesn't recover very well because the blood supply and the venous drainage and the lymphatic drainage, like you mentioned, they all come from behind here, don't they? So they come up from the chest in here, and they come out underneath the collarbone and then down through the arm there. So it's that area there. It's like the gatekeeper to the upper limb. It's fantastic. It's fascinating, right?
Yeah, definitely.
People just think, oh yeah, you've got nice clavicles and they look great, but it's like they're so bloody important.
So much more.
So important. Sorry?
So much more to it than just kind of a long bone.
Yeah, exactly. Yeah, it's really interesting. Are there any bones in the body that you find particularly interesting?
I think I like the ribs. I like treating ribs as well. I think it's something that sometimes people confuse. Sorry?
It's just because you like to eat them.
Yeah, I do like actually.
Right.
I feel some people concentrate on the spine, and then sometimes we forget the whole structure around it that actually makes our rib cage. And I like treating the front of the ribs with the sternum and everything, which is related as well to the top with the clavicle. But quite a nice area.
Yeah, it's quite an important area, isn't it? So, what are the other bones that make up the shoulder complex for those people that are listening?
Yeah, so you have the humerus, which is your arm bone. That's the ball part that comes into the joint. And then you have this really weird shaped bone, which is made of the scapula, the acromion, and then the glenoid joint, gleno?
Coronoid.
The round.
Yeah, the coronoid process. Yeah.
And it's a really weird shaped bone with kind of bits of bone coming across. And that's the three bones, if I'm not mistaken. Yeah.
It is a fascinating bone, and that's probably my second most favourite bone in the body, purely because it's such a weird bone, isn't it? It's what is it? It's just the shape of it. It's got this really flat area, which is like we were told when we did our acupuncture course. It was one of the areas that you've got to be really careful on because it's so thin. The acupuncture needle can actually pierce it, and you've got the lung on the other side, so you have to be like super careful when you're having treatment on that area. But it's actually, like, I know lots of rugby players, for example, and they have a lot of impact on the back of there, but because it's so flat, it absorbs the impact really well and distributes it over quite a wide area. But there's loads of muscles attached onto the scapula which make it really useful for be able to like transmit forces through it, but it's not very good at absorbing impact or having specific force put through certain parts of it. So it's a very interesting bone, isn't it?
Yeah, and he also needs, because he doesn't attach to any other bone, he just needs to glide through the rib cage, which is very interesting as well. As soon as you lift your arm, it needs to open up and then glide through, which I think is also
nice. It's very interesting. There's the big we have there's a little sac of fluid that sits right underneath the scapula, which allow it to slide. And some people, when they're I don't know if you're watching at home, but just say yes if this sounds like you. And when you're moving your shoulders around, they're kind of grating or grinding. That's a really common symptom of that kind of scapular dysfunction, isn't it? That people often get, and it doesn't need to be symptomatic, so it doesn't need to be painful. And often people have it for a long time and they don't really think anything of it. I know sometimes when we treat people and their scapula and shoulders are very stiff, you actually go back through that process. So you actually give them a bit of like what we call crepitus, which is the sound it's making. But that kind of grating or grinding sensation is quite common once someone's shoulders starting to move better. but you need to try and keep it moving and give people exercises to help continue to make it stable. So that's quite key. But yeah, they're always quite worried when their shoulder starts grinding. They're like, "Oh, Steve, oh my God, now my shoulder's grinding. I didn't do that before. Why is that happening?" Oh, it's no problem. It's not a problem. You don't need to worry about it. Just chill out and you keep the shoulders moving and try and stay active, because that's super important. Yeah, so there's 4 joints, aren't there? So they're all held together. There's ball and socket joints and plane joints and a condyloid joint, or that saddle-shaped joint for the SC joint. And then there's a functional joint, which is a scapulothoracic as well, which is important. But what kind of injuries do people get around their shoulder that you see in clinic?
Yeah, so type of injuries mainly, I'd say probably muscular, so it goes with the muscles of the shoulder. The main ones, we call them rotator cuff muscles, which is 4 muscles that comes in from your main skeleton all the way up into your humerus. So we talk that's your arm bone coming as the ball into the joint. Do you want me to name them? So,
I think it might be quite useful for people at home to understand like how it all fits together.
Yeah, so you have the subscapularis, you then have the supraspinatus and the infraspinatus, and then did I forget the last one? I can't remember if it's teres minor or if it's pec major.
So teres minor is part of the rotator cuff. So yeah, teres minor, supraspinatus, infraspinatus, and subscapularis. So they form the 4 muscles that bolt the shoulder, the ball and socket joint into place. But they're pec major does help with stabilizing the shoulder joint, but because it's a prime mover, it's not a very good supporter of that. So that's quite interesting as well, because when you get people that come in with shoulder problems, one of the biggest causes of shoulder problems that we see in the clinic is people that have been young gentlemen, normally around the age of 15, 16 and 17. And it doesn't affect them so much then, but it catches up with them when they're in their mid-20s, and then they go and sit at a desk for a long period of time, and their pec muscles end up really short in here. So that's quite a common age group to start to get these kind of shoulder problems.
Yeah, that's the pectoral muscle that's narrow that really treats. I think that's the mistake in there. But yeah, so they come in right along here and then within the shoulder.
Yeah.
And desk posture, we tend to round the shoulder inwards like this, which is reduce the length of these muscles, and so they get really tight through there.
Yeah, definitely. So when we see people with that in clinic, we tend not to. One of the common mistakes that's made is that people tend to just address the shoulder posture. But we tend to think of the body as being a collection of slings that kind of join together. So when someone's very tight in their shoulder muscles here, it's often a good idea to have a look all the way down through their body, just at that sling of muscle. So you're going to find that the muscles at the front are going to be very short. So you want to try and lengthen those. And then the muscles at the back often end up being quite weak and long. So it's a good idea to look at strengthening those. They may not always need strengthening, but that's kind of how you have a rough idea of how to go about dealing with those, isn't it? So do you find that there's any key things when you're looking at someone with a shoulder problem in clinic? Are there key things that you look for when you're testing people?
Yeah, so I'd look, one of the big things, I'd look at the thoracic spine mobility.
Yeah.
So looking if you're constantly like that, if your thoracic spine, so the spine just in the middle of your back, can't move, you're not going to be able to move and to kind of come up and go to an upright position either. And also because there's muscle all around that connects with the spine. But you also look, as you said, further down. So there's muscles that come all the way up to your spine and your shoulder that goes all the way down into your pelvis. So it's really connected through there as well. So you'd look at really the motion of pelvis, spine, the ribs, as I said, because the ribs are where the scapula slides through, as we said before. So if there's a restriction into the ribs, and then you might get the scapula moving a bit differently or moving not actually in sync with your whole body.
Yeah, so that's an important condition, isn't it? Because it's called scapular dyskinesis. So abnormal scapular mobility or movement is often what you see there. But that's a really common thing, isn't it? Because when people start to lift their arm up in clinic and they've got a shoulder problem, what tends to happen is that they tend to have a bit of a reversed scapular humeral rhythm. So they lift their shoulder up first before they elevate it, rather than stabilizing and then trying to elevate. And this kind of comes through as a result of that. So yeah, it's the fascinating joint, isn't it?
Yeah, they might do that because they feel like it's painful when they just do that, and that might come from the injuries to the different muscles as well that we talked before.
Yeah, definitely. Yeah, really interesting. So what would you say the most common condition is that you see in the shoulder joint in clinic?
I'd say it's some kind of injury to the rotator cuff, or a bursa inflammation. So the bursa is the sac of fluid, as we talked about with the scapula, that helps the joint glides, and then the muscle that glides as well on top of joints. So sometimes where it gets this bursa can get inflamed, and then it starts to overflow a little bit, and then create some pain and decreased mobility into the shoulder.
Yeah, it's good. So when someone comes in with those kind of conditions, how would you, if it was an average condition, so obviously everything's very individual to the person that's affecting, but if it was like a typical rotator cuff injury, you've diagnosed it, is there any other diagnostic things that you might do with people in clinic to make sure that that's what's causing the problem?
Yeah, so we have a ton of different tests in the clinic to do with the shoulder. This kind of, I think it's one of the part of the body where there's the most tests that you can do. So I would go through all of that. But one of the big thing as well with the shoulder, because it's such a complex area, we tend to like to having maybe some kind of imaging of someone looking at it from an ultrasound point of view to really make sure that we target the right area. Depending, because it's going to change a little bit if you have a bursa, if you have a muscle, if it's a ligament and things like that. So an imaging might be a good idea to make sure that you work on the right area.
Yeah, so ultrasound is quite useful. We actually do that in the clinic to actually have a look at people's shoulders, but we often refer out for MRI scans or imaging because that's quite useful because we can see inside the shoulder joint to actually work out what's going on there and get a very specific diagnosis, which is really helpful to manage it. So once you've got that diagnosis, Morden, it's been quite clear that it's a rotator cuff injury. How would you tend to approach that with your osteopathy skills?
So it depends what it is. I would probably, if it's kind of a tear muscle, it needs a little bit of time to heal. So first you would start doing more work a little bit further away from the shoulder to let some time for the muscle to heal. And then as it's healing, you'll start to kind of challenge the muscle a bit. So we would improve the range of motion, try to strengthen the areas that need to strengthen, and look at things like that. I also work on fluid drainage and things like that. So if there is inflammation in the shoulder, it's really good to keep fluid going, and that helps with the inflammation and help with the healing process.
Yeah, no, very interesting. And then what would you do?
And then I would probably look at what caused exactly this. So, for example, if the person has been doing kind of overusing the shoulder, so why exactly happened to this area? It might be because another part of their body are not actually working as well as it should. So then they're overusing their shoulder. So you would look at this other part of the body and try to help kind of to find a real cause of the problem.
Yeah. Oh, it's a motorbike.
I know, windows open.
It's loud, isn't it? But yeah, that's. I mean, that sounds fantastic. So, what's the first step of people if you're going to give people top 3 tips of like how to manage their shoulder condition? What would you say the key things are going to be to take away from that?
I think one of the key things, people tend to, as soon as they get an injury or something like that, put their arm in a sling or stop moving. So it depends which injury, of course. So if it's broken, of course, but if it's more of a muscle type injury and things like that, it's actually not the best to just keep your arm from not moving, because you completely stop the whole fluid drainage. You stop every muscle to contract and the normal physiology of your shoulder. So I'd actually say don't be scared of doing a little movement in the range that you are able to do, and keep that going to make sure that the blood flow is keeping on going and you're helping the healing process. I think don't be scared to go and talk to someone and explain how it happened, and they'll probably ask you a lot of questions and do a lot of tests, but by the end of the day they will find exactly what's wrong with you, and they'll be and that's when they can really help you the best that they can, because they know exactly what's happening. And third, not sure with shoulders. Do you have it?
I like your second one because I think it's really important. There's a temptation to want to get the shoulder treated because it's painful, but sometimes when you commit yourself to treatment, you can be ending up in a long-term treatment rather than actually spending a lot more time investigating at the beginning, maybe 1 or 2 sessions, really nailing down what's going on with the shoulder, and then move forward with treatment. Now, it sounds obvious because you need to find out where you're working on before you treat it, but there's a lot of people that come in, don't they, with shoulder problems in here, and actually it's not their shoulder, it's their neck or it's their back, it's something else that's causing the problem. So I think your third one's probably going to be related to be very clear that it is your shoulder causing the problem, and it's not coming from somewhere else. So that would be my third one for sure, because that's often dismissed.
Because we did, I think it was a few weeks back when we talked a bit more about referred pain, so pain that's coming from another part of the body but that's referring into your shoulder, for example. So it's making sure that the pain is coming from the shoulder, it is not coming from your neck or for other part load on in your body. So yeah, true, that'd be a good one.
Yeah, brilliant. Good. So listen, if you're watching live on Facebook, we'd love to hear about the type of shoulder problems that you've had. Just pop your details in the comments box below if you've had shoulder problems, or if you want advice on shoulder problems. We're always happy to kind of give advice and hopefully put you in the right direction of what you should do next to be able to move forwards with your condition. But Maud, what joint are we going to talk about next week on the Power Hour?
Well, I think we said we're going down in the body.
Yeah. So we go down this way or down this way?
Yeah, that's what I was thinking. Are we doing down to the limbs or down this way?
So you go down the limb.
Yeah.
We'll talk about elbow and we'll talk about upper limb injuries. So between your elbow and between your shoulder, because I think we don't want to miss biceps issues because they're really common. A very common cause of shoulder problems in the front of the shoulder here, and they're often kind of misdiagnosed. So we'll definitely talk about those. But if you're listening live on Facebook, then we really want to hear back from you. And if you're listening on the replay, we'd also love to hear back from you. So just put #replay in the comments box below, and we will look forward to seeing you guys next week. But for now, bye from me.
And bye from me.
Bye from you. Take care, guys. Have a great week. See you later.
Bye, everyone.